think we'll go ahead and get started.
Okay, great. Welcome, everyone. Thank you, Shelley. This is the Protocols, Medications, and Devices Standing Committee meeting. Today is July 10th, 2025. The time is 12 noon. I will call this meeting to order. Can we get a roll call, please?
Amber Rice. Erin O'Connor.
Present.
Brian Smith.
Present.
Christopher Key.
Present.
Thank you. Libby Jordan. Bronco Castramarin.
Present.
Garth Gamer.
Present.
Heather Miller. Is absent. Jason Johnson.
Here.
Josh Gaither. Matt Shaw. Paul Dabrowski.
Here.
Philip Hannon.
I see you off mute. Philip, we can't hear you, but I just do see you off mute.
Dr. Hannon, if you could come off of mute and let us know you're with us. Shari Brand.
Present.
Thanks. We have quorum.
Thank you. We'll go ahead and start with the chairman's report. We have an attendance report here on attachment 3A. We currently do not have any vacancies according to our notes. And also we have the 2025 meeting agenda available online for your review. Just a reminder that if any member of the committee misses 2 meetings in a row, we will reach out and ask about your continued interest to participate in the committee. And otherwise, we'll.
I fixed my mic. I'm sorry about that.
Oh, thank you, Dr. Hannon.
And otherwise, we'll move to the bureau report, please.
All right, I can go ahead and give the bureau reports. A couple of announcements. We are continuing our search for the bureau chief, so that job is posted. Thank you, Kim, for putting that in the chat. For strategic plan updates, we're working on developing our operational plans for this fiscal year. For EMS for Children, the MARC program has recognized 6 agencies thus far. That's really exciting as that is meeting one of our national performance measures for the EMS for Children program. And the EMS for Children program is also continuing to offer the neonatal resuscitation program training. For naloxone leave behind, we have 62 agencies participating and over 4,000 providers trained, which is about a quarter of the MCTs, nearly a quarter of the MCTs in Arizona, which is really exciting. For the SHARE program, several updates there. We are currently working on transitioning our CEDAR application, which is the hospital reporting tool, to REDCap. So that should be happening in the next several months. We will be sending out different communication as that progresses. We are also nearing the publication of the 2024 SHARE report, so stay tuned for those. That's been a long time coming. And then also the PEEP data quality reports for SHARE have been happening monthly since April. So if you have any questions about that, please contact the inbox link. At the May STAB meeting and EMS Council meeting, we recognize this year's EMS and trauma winners. So those are listed on our website if you're interested in checking that out. And then lastly, a trauma registry update. State Trauma Data Repository is not quite ready for Q1 data submission, and Chris will reach out when that changes. That's all.
Thank you so much. Heading now on to the discussion and action items. Item 5A is to discuss, amend, and approve the draft minutes from our March 20th meeting. Can I have a motion?
To discuss. Amber.
Amber and Josh. Thank you.
Any discussion? Hearing none, all those in favor to accept the minutes as shown, please say aye.
Aye. Aye.
Any opposed? Thank you. That motion will carry. Item B is to discuss the recently published NAEMSP guidelines for the pre-hospital management of hypertension in pregnant and postpartum patients. Is there anyone on the board that is prepared to present this information?
Sure, I can cover that. I'm not on the board, but I'm happy to cover that on behalf of the Bureau. So this was a recently published position statement jointly from the NAEMSP along with ACOG, the American College of Obstetrics and Gynecology, really looking at how to improve outcomes from maternal morbidity and mortality. And so with this being kind of a new national standard, this is kind of mid-cycle for the NASEMSO model EMS clinical guidelines. Those are pending, hopefully final funding to start the next update. But this is a positions kind of a new plan that was put out there. And so we wanted to bring this to the committee to consider as we wait for the process to update our guidelines. Historically, we update the TTTGs based on updates to the model EMS clinical guidelines. That process at the national level is pending funding and usually is about an 18-month process. So we'd realistically be about 2 years, it's my guess, from when we would look to do kind of a full TTTG update. And so in the interim, with this being a national standard, wanted to bring that to this committee for consideration. So these are several documents that talk about elevated blood pressure in pregnancy and postpartum state. If you can scroll to the next page, please. So it gets into blood pressure management at different levels of EMS providers. You keep scrolling. In addition, talks specifically about targets for blood pressures, when to use magnesium. There was also some other ones that I don't know are linked here as well, but in regards to postpartum hemorrhage and managing that. So that was kind of the impetus of bringing that to this committee for consideration, is looking to potentially update some of our maternal guidelines, as there is a big focus on reducing maternal morbidity and mortality, as this has been recognized to be an increasing problem in the United States. So that is a little bit of a background prior to us going to the next set of discussion items. Anyone have any comments on that? I don't know if anyone was involved in the NAMSP approval of these or discussion of these at all.
I can comment on the approval of these, discussion of these. So I'm the chair of the NAMSP Standards of Clinical Practice Committee. Currently, that committee reviewed these and the board of directors obviously approved the recommendations. I think this is becoming the standard of care across the country, as Dr. Bradley commented on. These were very not controversial. These were very broadly supported. So from at least that national organization.
And that is good kind of background to have, because I think sometimes things that do get brought forward to that committee are a little bit more controversial, not necessarily the same evidence base to back that up. So I definitely think that that is useful. So thank you for that background. I think that
I just posted in the chat box the NAMSP website that actually links to both what we're showing on screen now, as well as the postpartum hemorrhage document as well. So those are the links right there. Those three sort of orange colored deals. And they'll take you to those pages for anyone who wants to have a closer look. In terms of the one that we were looking at just a moment ago with the blood pressure, from a clinician standpoint, really what it's doing that's different from what Arizona has listed now on the T3Gs is really emphasizing antihypertensive therapy as a first line, in addition to magnesium sulfate, which is traditionally what we've been encouraging. Any further discussion? Okay, so hearing none, that'll take us to item C, which is then applying this information here, discussing, amending, and approving a draft T3G for maternal hypertension, and that's attachment 5C. And really, this is going to pertain to the bottom area here in the paramedic section, showing those same three antihypertensives, labetalol, hydralazine, and nifedipine. The background here is that nifedipine is a oral medication that can be utilized if no IV access can be achieved. We have labetalol and hydralazine, although my understanding, and somebody correct me if I'm wrong, but there is no specifically preferred medication here other than labetalol has some contraindications, including asthma and bradycardia, and then hydralazine. Some resources consider this a little suboptimal because its effect on certain patients can be a bit dramatic and cause you to overcorrect blood pressures beyond your goal. But those are the crux of the what's being proposed here.
Make a motion to discuss Franco. To Amber.
Thank you.
Second.
Second.
And I'll kind of give a little bit of some background on this. As we looked at the different maternal guidelines that we have, we really had the kind of focusing more on childbirth and recognizing that this is really a separate category. And so this was taking into account the recommendations from those national statements regarding the goal blood pressure, the time frame. So I think that's really the important thing to recognize. So if your agency has a short transport time or relatively short transport time, this is not going to be something you would use in terms of the antihypertensive meds, because it's really for 2 persistent measurements for 15 minutes. So I think that is one of the concerns that when we discuss this, for a little bit of context, I think everyone in this group on PMD remembers we spent quite a bit of time at the joint PMD and MDC sessions discussing different blood pressure medications and concerns that people had in regards to adding those to the drug tables. And so wanted to have a little bit of background with that. So I think one of the pieces in the NAEMSP document is really kind of very clearly delineating that this is for persistent hypertension, 15 minutes or longer. So for agencies that have a longer transport time, this would be really important so that maternal hypertension does not continue. If your agency has a relatively short transport time, this would be something that could certainly be left to be managed once they arrive at the hospital. So I think that is kind of one of the important pieces as we look at this as a potential draft guideline to adopt. You can kind of see at the top if you want to start there. So this very clearly identifies who's included. So it's patients after 20 weeks gestation, up to 6 weeks postpartum, any patient greater than 20 weeks with gestation with a seizure. And then we hyperlink to if it's childbirth to active labor, they go to the childbirth page. If it's postpartum hemorrhage, you can refer to shock. And then kind of streamlined a little bit under the EMT level of care, as well as just emphasizing under AMT, again, refer to shock as necessary. And then under the paramedic section is where it gets into kind of symptoms of hypertension, and then in terms of the dosing as well. So this is kind of the draft consideration here.
I have a couple of things what will more likely be controversial. Purely a formatting perspective, it appears that we have 3 categories of patients. Both of those categories of patients are underlined. The first one is what I would consider moderate hypertension plus symptoms. It appears that group only gets magnesium. Then the next one is hypertension. It doesn't appear that symptoms are required. Those get a blood pressure med and magnesium. I'm wondering if we need to get rid of or combine these somehow. When I read through it, it was just very confusing as to why wouldn't we put, so if your blood pressure is 165 and you have symptoms, you would not fall into this protocol. Is what I'm saying. So maybe a little complicated, but I think we could probably just get rid of your combined bullet 1s and 2s to say systolic greater than 140, initial treatment mag 4 grams. If persistent hypertension after 15 minutes, repeat your medications. Something to that effect.
Both of them with symptoms as well.
I don't think you have to have symptoms either way.
Okay, so I had a question about that. Do we exclude patients with a history of hypertension then? If they're always sitting at 150 and they don't have symptoms,
That's a fair question. I haven't thought through that.
The only thing about combining them just as is, I agree that we can do some formatting changes, is that if we combine them, then it will be unclear as to the blood pressure medications are really for a higher systolic than that one. So potentially we could just add magnesium underneath the higher blood pressure reading.
Yeah, and it's here, it's just not folded, which threw me off.
Yeah. So maybe that would be something as just like the,
I think we all could agree medically, the initial treatment is magnesium, followed by repeating the blood pressure after 15 minutes and then considering your antihypertensive.
and I think
I'm sorry.
the reason I think for just, it was matching the document for the NAMSP was it lists the hypertensive first and then MAG for that category, but certainly if it was folded, I think that may make a little bit more clear.
They did, yeah, just consistent.
Yeah.
Maybe then for the greater than 160, we could just add a with or without symptoms.
Yeah, that would work.
That would
Yeah.
work too.
Yeah.
So kind of just making sure you're capturing the edits for the first bullet or second bullet under paramedics. So the systolic blood pressure, no issues with that one. But then the third bullet, adding in the header with or without symptoms, colon, and then bolding magnesium sulfate.
Yeah.
A loading dose if we're not giving a subsequent infusion. We just want to like the rest of the areas, we just said give MAG IV over 20 minutes.
Yeah.
And then down below, we call it a loading dose. We want to just say give 4 grams and not specify that it's a loading dose. We're not really calling it with an infusion.
Loading dose.
So just 4 gram IV.
Yeah, just so it sounds the same. Because loading doses are usually followed by something we're not following.
That same thing under the further down.
To your question about if they have, I think that's the discretion of the paramedic to say, and would be good documentation, hey, I didn't take my blood pressure meds today. My blood pressure is normally 150 to 160 systolic. I'm going because I sprained my ankle, not for pregnancy related complications. I think that would be the discretion of the medic to just, not as to why they didn't treat it per se. But I don't know that the guidelines don't necessarily get into that level of detail. I think that would just be the cleaning piece. But definitely a good point.
The other nitpicky thing, last bullet on the page, can we add in, so this reads to me, pregnant patient greater than 20 weeks. It doesn't include your postpartum period. Can we make it say pregnant patient greater than 20 weeks gestation or within 6 weeks of delivery or something like that,
Yes.
just to make it clear.
Let's say that.
I would just phrase that the way the NAMSP document has it very elegantly, just 20 weeks of gestation and up to 6 weeks postpartum.
Easy fix there. The one thing I did point out, and this is from the NAMSP document, the time frame for the magnesium is relatively long compared to what our current version is, it's saying 20 minutes. So, but that is what's in the national guideline. But I did want to just point that out, that is longer than the time frame, especially for a seizing patient that we have historically had it. So.
Well, that was my logic behind saying we start with magnesium, right? So if you need a blood pressure measurement 15 minutes apart to get to your antihypertensives, you should probably start your magnesium in that interval. So just purely operationally, I would see at least me implementing this as you get a blood pressure, it's greater than 160, you start the MAG. After you finish the MAG, you recheck it, and then you give antihypertensives. Okay? Or still hypertensive. If the blood pressure goes down, which it probably will with the MAG, then you don't.
For the antihypertensives, are there any, do we want any repeat doses or max doses? I know that'd have to be a pretty long transport time to repeat any of those.
Transports do exist though.
Right.
So yeah.
I think typically these are kind of considered the offline guidelines for most entities. So there's always the opportunity to contact online medical direction for kind of those situations, but I don't know that I would put in repeat doses for these, just because this is going to be a pretty sick patient that's pretty complicated. So you'd want to make sure at that point, if you are considering repeat dosing, that you're maybe looking at what's your transport time, where are you going, things along those lines.
And now, Gail, do you mind giving the board just a little bit more context? I initially didn't realize this in my head, but this page would be a separate page from the current OBGYN conditions, and then as well as childbirth. So essentially we'll have 3 pages now that fit under sort of an OB gynecology framework. Is that correct?
Or we just replace the OB gynecology conditions.
So I didn't catch that over the phone. So this would replace the one that is currently titled obstetrical gynecological conditions?
Yes.
I think so, because there's,
It's seizure management.
yeah, totally.
I think so. I did share that one as I'll find it if we need to pull that up to see. I do have a strike through that it sent.
Do you intend to discuss the specific medications separately, Gail?
Yes.
So let me look at how the action, no, those are, so the first is to kind of look at this as a guideline. Then we would look to add it to the drug box. So certainly if there's concern on kind of this is, and then we can also look at the verbiage and consideration of whether or not we want to approve it. Otherwise, we have to go back and re-vote on this. So I think we can discuss some of this here, and then the next step would be voting on the drug box.
I mean, after formatting, I have a couple comments on this medications, but I'll get through what are the other formatings?
Any other discussion on the guideline itself?
Well, I was just gonna say if you or ask if you wanted to add a line at the bottom if hypertension with symptoms, or if hypertension and seizures persist, then online medical direction should be consulted. Or is that understood?
I don't think any of our guidelines say that, and that's probably just true to all of them.
Yeah.
And Franco,
That's
maybe,
good. Mhm.
oh, sorry, go ahead. I think Amber and I both probably have some comments on the bullets of meds. I'll start out with the background, and then I'll save my comment for later. The background on these meds was when NAMSP sat down to decide which meds to list here. It was very much arbitrary. This is a list of commonly available medications, not necessarily intended to be all-inclusive. It doesn't include all the meds that you could use, and it was not necessarily intended to be all on the list. So I think it is probably worth a discussion for our state. Do we want all 3 of these meds? Do we want 5 meds? How do we want to manage that part of it? I think that's what your comment was on too, right? I'll tell you my concern here. We have a lot of medics who work at multiple different agencies. The dose of labetalol is 20 milligrams. Anyone want to take a guess at how many milligrams are in one vial of hydralazine? 20. I'm a little concerned this is a setup for medication dosing errors, that if I train my Tucson Fire Department to use labetalol at 20 milligrams, and they go work an overtime shift at another agency that uses hydralazine, they pick up a 20 milligram vial and they see, oh, it's 20 milligrams. I just give the whole vial. And it's just one of those type 2 errors that's very, very easy to make. So I'm a little hesitant to list both of these for that reason alone, but I'm very flexible. I'm not saying this is where a hill I'm going to die on. Just wanted to bring it up.
Yeah, my concern specifically is with hydralazine, probably very much related to Josh's point. Hydralazine tends to be the one that causes the most, if given too quickly, rapid decrease in blood pressure, which could be dangerous. And so I think that in combination with the fact that if there was a medication dosing error, likely to be an overdose, not an underdose. And that would be my big concern with hydralazine. So from my perspective, if we were going to take any of them off the list, I would recommend taking hydralazine off this list. And then nifedipine obviously is oral, maybe a little bit easier to dose and less prone to medication dosing errors. Labetalol has a few contraindications with asthma and things like that, but I think for me, the hydralazine was is the one I'd have the most concern over. I would recommend removing.
Overall, I think this is a very good thing to move forward with. I don't want to take any of my comments to be against the protocol all in all. I think it's a positive step.
Any other comments specifically on layout or other content concerns before we get into the finer points of the medications? It sounds like the board is otherwise at least in consensus to move forward. It sounds like. Gail, is it okay if we just have a vote as is on the on item C in terms of approval with amendments as discussed?
I don't know that we have any amendments yet, Franco.
Excuse me, the edits.
The edits. So the edits were just clarifying the with or without symptoms, the holding, and postpartum. So those are all edits.
Yeah.
The question would be, do we edit the hydralazine?
Right.
Or remove hydralazine? So I think that is this piece for this guideline. In order to vote on this guideline, there would be a friendly amendment if someone wanted to make to the motion of keeping that or removing that medication option. So
I would make a motion to remove hydralazine.
There is no preferred medication, like of the three or of a different three. I don't know, like,
Yeah.
and there's no real one better than the other.
No, hydralazine, you risk hypotension. So I make a motion to add that also to it, removing as an edit.
I will second that with the comment that we can always come back and add it later. If, for example, we have a shortage and labetalol can't be obtained, we could come back and add it as optional.
Do you know anything about the cost of these meds to add to a drug box?
Oh, I just looked it up. I'm not that fast, but I will tell you in a minute.
generic, it should be relatively inexpensive, I would think.
Right, what page for that? I'll get there if you want to hold that for a second.
So we have a motion to strike hydralazine from the guideline as it currently shows. Any further discussion on that? Hearing none, can we put that forward to a
Sorry.
vote, please?
It's Aaron O'Connor. I couldn't get off mute fast enough. I apologize. I guess the only thing I will toss out there for consideration is should a pregnant patient be on a sympathomimetic and be hypertensive, is there any chance that this will be applied to them, or will we be able to distinguish preeclampsia and pregnancy of hypertension? Like, I guess I just worry that if a patient is sympathomimetic, could somebody apply this to them? If so, labetalol would not be optimal to give to that patient. So hydralazine actually would be favored in that scenario. If the patient's, got extreme hypertension from cocaine or something, or in our neck of the woods, methamphetamine, which I know everybody says there's no unopposed, the whole unopposed alpha is overblown, but I've actually seen it happen. So having an alternative agent might not be a bad idea. I will just stop there.
I would probably only add that I doubt agencies would carry all three. My guess would be they would just pick one and they would carry that, and it might be labetalol, or it might be hydralazine, or it might just be nifedipine, but I doubt very much they'd be carrying multiple. So like there would have to be some, there's obviously an education component that's going to go along with it, where if labetalol is the only drug that your agency is carrying, then you should know about the risk factors of what patients should be receiving it.
That is something we could certainly add to the drug profile. So I think that is a good addition, Aaron, to consider. I don't think that is captured in the drug profile. So when we get to that, we'll make sure that can be put in there as kind of a contraindication.
Just to follow up, I'm very surprised, not to distract Aaron from your comment, but labetalol is dirt cheap. It's like $1 a vial. Hydralazine, I don't know why, is not cheap. 20 milligram vial, runs $1,000.
No way.
I know.
That doesn't say case slot on it.
It may be a case.
That $2,000 is for 25 vials. I'm looking at
Yeah,
it.
it's $1,000 for 25 miles.
Oh, for 25.
But still, that's a lot more
And
expensive.
I doubled down on my amendment.
I would like to stock in that.
Done.
Yeah.
Okay, that's the boundary price.
So the motion on the floor is to go ahead and strike hydralazine. Any other comments on that? Hearing none. All those in favor of striking hydralazine, say aye.
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 Any opposed?
One opposed.
That's abstentions? Okay, that motion carries. And so the remaining medications will be labetalol 20 milligrams IV versus nifedipine 10 milligrams orally. Any other changes to discuss on the guideline itself?
I guess just to kind of tack on the question, in the parentheses next to labetalol, we have avoided history of asthma or bradycardia. Do we want to add in there, so avoided history of asthma, comma, bradycardia, comma, or sympathomimetic ingestion?
Or English,
Or
cocaine/methamphetamine ingestion.
I would be in favor of either, whichever way you prefer to. I don't know if the other guidelines have it, but sympathomimetic toxicity and or stimulant intoxication.
I agree. Probably using more of the generic drug term is probably make sure people know what they're actually looking for in terms of the use. So if we did avoid a history of asthma, comma, bradycardia, instead of bradycardia, comma, or cocaine/methamphetamine ingestion.
The only issue with that is that it's not really that we're worried about a history of bradycardia, right? It's actual bradycardic presentation.
So we would say avoided history of asthma, comma, current bradycardia, or cocaine/methamphetamine.
You can just get rid of history.
Intoxication, yeah.
Yeah, intoxication. Yeah. Well, it is
Or
history.
put
of asthma.
bradycardia at the end. Avoided history of asthma or stimulant use, whatever you're gonna put there. Or if patient is bradycardic.
Currently bradycardic.
Yes, I'm just move bradycardic to the end.
All right, so for the sake of time, any other edits, comments? Okay, unless anybody says different, it sounds like we're ready for a vote. All those in favor of the current OBGYN conditions, including edits as discussed, including elimination of hydralazine, all those in favor say aye.
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 Any opposed?
Aye. Nay, whatever.
Abstentions? Okay, that motion carries. And now we can take a look at the draft updates to Table 1 based on these efforts. This is the EMCT drug box reflecting the proposed addition of labetalol hydralazine for paramedics and adding nifedipine for both paramedic and critical care endorsed paramedic, attachment 5D. Can I get a motion to discuss?
Motion to discuss Franco, it's Amber.
Second.
Edits are highlighted in yellow.
In light of what we just discussed, my recommendation obviously would be to just remove hydralazine.
For nifedipine, it's not listed specifically as oral versus IV. The protocol obviously calls it oral. Do we need to specify, or If we leave it generic, then
I think it's only available
I think it only comes in.
orally, right?
Yeah. Okay.
I don't know that there's an IV formulation of that. Yeah. But we could specify. There you go.
I mean, I'll just point out on these lists, you know, and sometimes we group things, but then we list other, like Haldol and Droperidol may be grouped together, or morphine or fentanyl. But then we have 3 different beta blockers not grouped. You know, we have, and it might not be this one. It might have been, sorry, it might be a different list. I just saw like esmolol, metoprolol, and labetalol list separately. And here, I guess it's metoprolol and labetalol. So I don't know if we want to be consistent and group class of medications that they may have an option of.
I think those are separate because those are all optional drugs to begin with. Things like diazepam, lorazepam, midazolam, they're ORs. They have to carry at least one of them. But they don't have to carry any of the beta blockers. They don't have to carry any of these antihypertensives. So I think that's why they're grouped. Some of them are grouped and some are not.
Well, droperidol or haloperidol, both optional.
That is a good point.
Yeah, but
Okay.
otherwise you
Sorry.
are correct.
That holds right at your theory.
Any other comments? Okay, so and I apologize, my audio went out for a minute. I think I may have missed a change proposal. Was it just the removal of hydralazine?
Correct.
Okay.
When I think
And so-
nicardipine we could stipulate or is oral, and nicardipine we could stipulate as IV. If that's,
I just looked and could not find any IV formulation of nicardipine.
That is
Sorry.
Maybe we don't need to be more specific. It's probably fine.
Yeah, extended release and immediate release tablets.
Okay, so again, sorry if the audio is not coming through on my end. It sounds like right now we can put a vote forward to remove or keep hydralazine. All those in favor of removal, say aye.
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 Any opposed?
yes.
Any abstentions? Okay, so that motion carries. Any additional comments before a up or down vote on the cumulative changes on this table? Okay, hearing none. All those in favor of approving the changes to Table 1 EMCT drug box as discussed, including omission of hydralazine, say aye.
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 All those opposed, say nay. Abstentions? And that will carry the motion. Thank you. Next, let's look at the individual drug profiles, starting with labetalol, attachment 5E. I need a motion to discuss, amend, and approve.
So moved. Second.
So I'll go ahead and start as discussed earlier, and under contraindications is that our space where we can start adding comments about sympathomimetic toxidromes.
I mean, I think it's worth, I know there's a lot of, you know, people consider the unopposed alpha effect to be kind of mythical, but I've seen it numerous occasions. And then I think the reason that I'm conscientious about it is because folks believe that, you know, because labetalol has either a 1 to 3 or, you know, 1 to 6 or 7 alpha to beta ratio, they feel it's safer to use. And so then they use it in that situation and they can get into trouble because it just acts like a beta blocker in that, you know. So that alpha activity that it has is not pronounced enough that it protects from having precipitated hypertension in the setting of sympathomimetic toxicity. So that's why I just like to create awareness in the event that, education is not, kind of highlighting these things.
Probably definitely worth putting on there. So adding, I think to be consistent with the guideline, then we say cocaine/methamphetamine intoxication.
Yep, that sounds good.
And I guess you like that better than stimulant or sympathomimetic, just because there's a lot of, designer substituted amphetamines and other things out there, and new items on the streets. So I don't know if you just want to, instead of just say cocaine and methamphetamine, maybe it is better to stick with stimulant toxicity or sympathomimetic toxicity for both.
Stimulants such as, for example, one of many. Questions about the overt heart failure line. Do we want to be more specific about what we mean by that? Like, are we talking about history of heart failure or heart failure with signs of fluid overload? I think sometimes that's hard to distinguish in a pregnant person who's got like lower extremity edema, pregnancy, and things like that. So I don't know if there's maybe something more specific we want to put in for overt heart failure, like, I don't know.
Acute exacerbation.
Something like that. Fluid overload. And if they were preeclamptic, they might look,
Fluid overload would be
I
tricky.
mean, they're just hard to, I don't know what we mean by that here. What are they looking for?
Yeah, this is kind of just coming from multiple different references as potential contraindications. Some of these were, like precaution with bradycardia as well as a contraindication. So, it's one of those things where you have to be adding the training component, but
I think we could clarify it with history of congestive heart failure with current evidence of volume overload. Or we could say current evidence of, or current dyspnea, or
Yeah, I would say I'd go more of a shortness of breath or hypoxia or something related to the pulmonary side. I think lower extremity edema in all these patients will be present probably if you're looking at somebody who's pretty
Right.
active. I like the respiratory.
the history of CHF with respiratory compromise.
Yeah, I like that.
And
Yeah.
then just
Yeah, I like the emphasis on the respiratory as well.
to make sure we captured regarding these sympathomimetic or stimulant use, just to make sure we have the right wording the group would like. Do we want to change it to stimulant? And I guess the question that I have is ingestion versus intoxication. I think intoxication is a very subjective term. If someone tells you they used cocaine or meth and they're not intoxicated, but they used it that day, wouldn't you still want to avoid using alcohol, right? So I don't know that intoxication in my mind is the right word, but if I'm incorrect, please.
you could say sympathomimetic ingestion.
Yeah, I like.
And then in parentheses, say examples, cocaine, methamphetamine, and other stimulants.
Or recent stimulant use, perhaps, because sometimes they shoot it up or smoke it.
When did you last use? It's been a while. It's a while. Of course. But I think these are really training guides to go along. So I think that is.
Any other comments or edit recommendations? Can you, Shelley, can you scroll up at the bottom just to see what the linked guideline list is?
And I'll swap
There,
out.
perfect. Okay. Great. And why does it say protocols containing aspirin?
I'll swap that out for a little
Okay,
bit.
okay, gotcha. Okay.
But
Any other comments before a vote?
Brian has his hand up in the room.
Just a thought, years ago, a long time ago, like in 92, when I became a paramedic, we had nifedipine in our drug box. And it was removed from our drug box because of concerns with hypertensive patients getting it when they were having stroke. And so I noticed that that is not on here for nifedipine, and maybe it's not an indication anymore, but I wonder if for labetalol, we should remove that and just keep it for its intended purpose of our discussion today for maternal hypertension and that, and remove the hypertensive crises or the hypertensive emergency in order to prevent people with stroke with hypertension from getting labetalol. Just a thought
The indication section,
in the indication section.
I think that's a good point. Can you scroll up a little bit just so that you can see it as indications? To be striking the hypertension.
That's reasonable.
That is as well.
Any other recommendations? Okay, so it looks like all three drugs were combined, and so moving on, hydralazine, it sounds like it's a moot point at this
No.
point in the conversation, or are we
Let's
keeping it?
circle back to item E, please. For
Uh-huh.
approve the,
Oh, I see. Yes, I'm sorry. I was looking at the wrong part of my agenda. I apologize. So yeah, so let's go ahead and move to a vote specifically for item E, which is to approve the draft drug profile for labetalol with edits as discussed, attachment 5E. All those in favor, say aye.
Aye.
Those opposed, say nay. Abstentions? And that motion carries. And so at this point, are we okay to skip item F since hydralazine has been removed?
yes.
All right, so going on to item G, can I get a motion to discuss, amend, and approve a draft drug profile for nifedipine, which is attachment 5G?
Second.
Second.
Brian,
And then Shelley, it looks like as was the case on the other one, we'll need to correct the term aspirin on the bottom.
yep, I do that.
Do we want to match the heart failure language as was adopted on the labetalol page here?
Yeah, I agree. We also on one say postural hypotension and one just say hypotension. I don't want to necessarily go back to it, but
That was very specific in some of the drug things online. I don't know if it's relative, if it's important enough from a pre-hospital perspective, but
I don't think
the drug guides were.
Because my ignorance, but what is IR under administration?
really.
No, immediate
IR
release.
tablets. Because there's ER tablets and IR tablets.
Do we need that?
I don't know what I mean.
If it's, I mean, I thought that was, I was trying to think if that was interrectal or something. In the root of administration.
Do rectal Valium, so
That's a different abbreviation, but I don't know what that was.
That's not where my mind went.
As long as nobody's puncturing it, we're good.
I know.
Josh is putting people's butts.
I would suggest removing the IR. How about that?
the one thing is all the guidelines do talk about for this medication. It is specifically the immediate release formulary. So
I would move it to the title.
Yeah.
To the title. That'd be
Spell it out, immediate release.
Concur with removing IR.
so we avoid Josh's interpretation.
Any other changes to recommend? All right, hearing none. All those in favor of approving the nifedipine attachment 5G drug profile with edits as described, say aye.
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 All those opposed, say nay. Abstentions? Okay, that motion will carry. Next is item I. Can I get a motion to discuss, amend, and approve an update to the T3G for childbirth, specifically to include the TXA dosing? This is attachment 5I.
If you want to back up a little bit, we had a item H.
Oh my gosh, I'm so sorry. I have to, in order to keep all these windows open, some of them are very small and my eyesight is fading here. So I apologize to the group. So backing up, can I get a motion to discuss, amend, and approve the update to the TXA drug profile, which is attachment 5H?
Motion to discuss.
Second.
Thank you,
Josh, that
Shelley,
was
for
typo.
keeping me honest here.
Wanted to This is pretty straightforward,
I
just
move
to fix this typo.
Okay, nothing else on this page? That's just it, the onset timing?
Correct.
Update the
Okay.
date at the top, that's fine.
All right, all those in favor for this change on the TXA guidelines, say aye.
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 Opposed, say nay. Abstentions? Okay, that motion will carry. And now we are at point.
I didn't capture who made the motion, Josh. And who? Did we get a second on that one?
Oh, Amber.
Thank you. Okay, letter I.
All righty.
Proceed.
Letter I. Yep. Can I get a motion to discuss, amend, and approve update for the T3G for childbirth with attention to the TXA dose, attachment 5I?
Matt, go ahead.
And so it looks, based on the highlight there, that we're changing to a 2-gram IV bolus. Dr. Bradley, is that the specific change?
Yes, it is a proposed change.
From 1 gram?
Correct.
Yeah, I'm sorry, I didn't do a strike view version.
Oh, it's okay. And so I'd like to hear sort of where that came from in terms of the impetus for the change, if it's just sort of a pragmatic decision or based on some type of RCT data.
I changed ours in the southern region a year or two ago based on the recommendations from our regional trauma center. So I think most of the regional trauma centers are currently giving 2-gram initial boluses, which is why we made our change in southern Arizona.
So that kind of speaks to one of my questions, which was, how hospitals would respond to a 2-gram pre-hospital dose. The as it happens, earlier in the meeting, we were being very careful about trying our best to match the NAMSP guideline. The NAMSP guideline on this dosing actually includes specific language that for postpartum hemorrhage, a 1 gram followed by another 1 gram after 30 minutes is evidence-based for this application, and they acknowledge that it may not match what others are doing in terms of other indications. But I just want to point that out for discussion.
We have a hand raised.
Yeah, go ahead, please.
Hey, everybody. I've seen this a lot from my end as well about the trauma docs talking about 2 grams. This just may be me not seeing it, but has anyone seen any papers specifically talking about improved outcomes and also just comparing to make sure that we're not causing more blood clots in the process?
Yeah, I'm aware of one off the top of my head that looked retrospectively at patients who got a 1 and 1 versus 2 and found no difference. I don't know that reference off the top of my head though, so purely my recall.
No difference.
When you say no difference, is it no difference in bad outcomes, no difference in good outcomes, or like the same?
Yeah, thromboembolic events or positive outcomes, either one.
Okay, because I know I was very pro TXA starting off, but it's still, the data has still yet to really pan out. So I guess if there's no harm, sure, but I just wanted to know if we were seeing any new data coming out showing of actual benefits. So I appreciate it.
We have a hand, Dr. Zeidler, online.
Hey, I'm sorry. So, you have the followed by. Was that supposed to be followed by the oxytocin or followed by an additional dose of TXA that isn't there?
It looks like we're missing the strike-through version, so that is a good pickup on the trying to pull up the current version to see what that look like. Yep, that is the goofy version we have listed in our current one as well. So
This was just to make it consistent with the dosing that we use in trauma, right? We just did this one first. Yeah,
correct.
I think to avoid confusion, Josh, your point's good though, right?
Yeah.
We probably should get rid of that followed by because many people don't have oxytocin in their boxes. I
Thank
don't
you.
think it's
Okay, so we will strike that language followed by going back to the 1 to 2 dose. My thought, I have some thoughts on this. The issue is, so it looks like there's some data coming from the CRASH 2 and STAMP trials. And really, as Josh already summarized those findings, that it seemed to suggest no safety issues. But there's question about whether the trials were adequately powered to detect those safety signals. And really just from a committee standpoint, my concerns are, in terms of setting precedent, that we're adopting a protocol change based mostly on pragmatic trends rather than true comparative data, especially when we have the NAMSP memo that specifically says stick to the 1 gram followed by another 1 gram after 30 minutes for this indication.
I would honestly love our paramedics' opinion in the room of, is it cognitively harder to remember 2 ways to dose it for different reasons? Or is it easier to say, hey, we're going to give 2? If you were
Well,
in
I
the
guess
field,
that goes to something. I mean, that goes to something here that's coming up in item J, which is the trauma dose of TXA, and my arguments apply there as well. Just because the trauma centers have adopted this dosing, the question is, do we bother to follow suit? Again, and just specifically with the way that this sets precedent in terms of adopting a pragmatic change over an evidence-based change.
And I still think this ultimately is going to be up to medical directors though, because we only carry 1 gram. We in our boxes we don't start the infusion afterwards. We deliver it with 1 gram to the hospital, and they can finish up whatever else. So I think ultimately all of this is going to be up to a medical director anyway. Whether we change everything to 2 grams or not doesn't necessarily mean they might go with it or they might not.
We have a question online, Aaron.
Yeah, I guess for me, I mean, I support what you're saying, which is if there's not evidence-based medicine or evidence, to the contrary, everything, I don't know what the literature has because I haven't done a lit search recently on this, but almost every indication that use tranexamic acid for starts with 1 gram. And then obviously the main concerns are thromboembolic phenomenon and then even seizures, which everybody forgets. But I would not be in favor of starting at 2 grams unless there's literature to support doing it. If you look at even like Lexi drug or something like that, every indication is 1 gram as initial dose, obviously then to be repeated. So, yeah.
Yeah, and that's the case with most trials that we have been using to support TXA at all, which again, some would point out have not shown robust improvement in outcomes, but rather sort of subset data, et cetera. Dr. Gamer, go ahead.
No, I like what you're saying there, and I am appreciative of Brian's point that they're only carrying 1 gram, and so to have this would automatically put them out of guideline. So in short, I like the 1 + 1.
I said 1 to 2 grams. initial bolus and give it a range.
The other part that I'm recognizing that we have in our trauma guideline that we don't have specifically in the childbirth for postpartum hemorrhage is that it should be within 3 hours of birth. So I think that is something that clarification, the dosing should be 1 gram within 3 hours of birth. So that is, we have in the trauma kind of injury, but we don't have that the childbirth one. So I do think that should be added.
100% agree. The 3 hour limit is important. Dr. Brand online, go ahead.
Just a quick question before I forget. Would the seizure prophylaxis and management under there, are those all the same as what we just did on the other guideline, just to make sure we follow back on that? We don't have that as highlighted, so I just want to make sure that it all fits with what we had talked about before with that too.
So, yeah, go ahead.
Yeah, I was going to say there is another draft version that is for some reason didn't, I don't know if I didn't share it correctly with Shelley. So I think that section would be just reference to maternal hypertension, preeclampsia, and eclampsia 1 rather than realistic none. So that would be the recommendation.
Okay, no, I just want to make sure that everything's consistent too. Sorry to divert from the TXA, but I just didn't want 2 versions on 2 different things.
Yes, I think for probably a good way to do that would be to strike out. So if signs or symptoms through the seizure management, and then just do a bullet that says for active seizure, refer to maternal hypertension, preeclampsia / eclampsia guideline.
And where's that going to go at?
At the very bottom. So if you look where there's under EMT I/paramedic, there's 3 bullets. The first bullet is postpartum hemorrhage. The second one is really talk about preeclampsia. We could strike that whole section and really just reference.
Right, the maternal hypertension, yeah.
Exactly.
Yeah.
Yeah.
Just for a quick question for the TXA, and then it says followed by oxytocin.
That's we have a strike.
We address that.
Because that would preclude you from giving it if you didn't.
Yes.
Okay, gotcha. Okay.
So back to the focus of this particular motion, it's to accept a change to show as highlighted from 1 gram to 2 grams. We've discussed other edits, including removal of the followed by statement, including the highlight that whole bottom section there will just refer to the guideline that we just amended, so as to not run into consistency problems. Any other specific arguments in support of this change for the 2 grams?
I could live with a range. I heard somebody talk about a range of 1 to 2 grams. Is that a possibility?
So Dr. Gamer, this is Franco. So I thought of that as a potential compromise, but then my question back would be, what confidence do we have that we're leaving it up to either a medical director or EMS clinician to distinguish which patient warrants the higher dose, which patient warrants the lower dose, especially when the higher dose, as we've discussed, is more of a pragmatic recommendation rather than an evidence-based one. And if somebody, unfortunately, were to have a thrombotic complication, then what have we done as a state committee to sort of, enhance or compromise medical legal defensibility in that setting? Because we have really no leg to stand on in terms of the safety profile here.
I follow.
I think my comment would be,
I'm with you, Franco.
Mm-hmm.
Franco, I think my comment would be that not all of our medications have robust data showing like extreme efficacy in the pre-hospital setting overall. We do give a lot of medications in the pre-hospital setting that are for treatment, knowing that they're going to a definitive destination for final care. And I think that for, at least for us in the Southern region, we prefer to work closely with our trauma system and as part of the trauma system. And so taking into consideration the recommendations and the treatment of the final destination, understanding that if the trauma center that's receiving these patients prefers 2 grams given within the first 3 hours of treatment, I think that it is easier to have that done all at the pre-hospital set time if we're going to give 1 versus 2. It just makes it a lot easier for those trauma centers to know that their pre-hospital patients are potentially getting 2 grams or could be getting 2 grams. So I don't think that all of our medications have a lot of data showing that they're necessarily better given in the pre-hospital setting. I think a lot of these are just medications given on at some point in the care of a patient. We just happen to have them in the pre-hospital setting. So I don't think that I necessarily agree with saying that just because it's pragmatic means that we shouldn't be doing it.
Your point's well made, and I certainly acknowledge that that's the case with a lot of other medications. But in this particular example, given that the trauma center has the ability to, it's easier to add something upon patient arrival than it is to take something away once it's been given. And so while it's, and then the other issue is that what your trauma centers have sort of requested of you in terms of teeing them up for of what they define as success, does that actually extrapolate to trauma centers across the state, which is really what the question that we're being faced with.
So just from a perspective of the rule of the meetings right now, so we are still on I. So I think just to make sure, let's maybe try to finish I and then kind of go to the Jade on the topic. I just sent Shelley kind of in the chat, if we'll chat, just so that the group can see kind of the draft version of what this will be highlighted as to take to MBC at the bottom there. So that way the group can kind of see the visualization under childbirth. So it'd be simplified. We just need to fix the bullet and obviously the hyperlink, but it would be essentially TXA, paramedic only, 1 gram IV if for 3 hours birth. So the new verbiage there. And then for hypertension or seizure, refer to maternal hypertension, preeclampsia, and eclampsia. So that would kind of simplify the current version that we have.
Yeah. While you're looking at this, then can I ask that Shelley, can you bring up the NAMSP guideline on the postpartum hemorrhage and scroll to the bottom?
There was a question in the room.
Just at the very top for the exclusion, the last word is seizures. That link, do we want to change that one as well to maternal hypertension?
Yes.
Yeah, so right there. See, right there. Yeah, right in the center, bottom of the page there, that comment. Given that we're trying to vote on item I for the TXA dose for childbirth. I just want to make sure the record shows that we've looked at that.
Can you zoom in at all?
Any other comments?
And then just scrolling to the top, just for the comment in the room. I think we could just replace this line and say, for hypertension or seizure, refer to maternal hypertension. We'll just finish adding that link in there. So that way it's consistent.
Any other follow-up comments?
I'll just point out that if patient's seizing, it's a relative contraindication to tranexamic acid, right?
I think for this guideline, we're kind of combining a lot of different postpartum complications all in one. So they're going to do their best to manage whatever they think is probably the most emergent in that scenario. Unlikely that they're probably going to end up getting both, but they're all kind of both in the same guideline just for, in general, childbirth complications.
All right, I'll go ahead and put it forward to a vote. Again, this is item I for specifically the TXA dose for childbirth, not to conflate that with the general trauma management, which is coming next. So the item for vote is to change from the current 1 gram, which you're looking at on the screen right now, up to 2 grams. We have made several edits along the way in this discussion. But the core item that we're voting on is that 1 gram to 2 gram bolus. All those in favor, say aye.
I want to clarify, I think that's confusing what the discussion and the vote will be, because we're asking to vote about changing from one, but he said to vote from 1 gram to 2 grams.
Is it all changes though?
Yes, I think just to clarify what the vote is. Are we voting on all the changes, or are we voting, because the 1 gram was the dose already in the guideline?
Right, but the item I is the vote specifically on changing that from the 1 gram to 2 grams. Am I mistaken there?
So for
It's
TXA
updated
dose.
guideline for the dose. So you want to table this vote, this discussion then, and then we would just. Shelley, I'll let you be a parliamentarian on this.
I think it's okay for everyone to vote nay on the dosing vote.
Yeah, I think that using prior logic, the rest were sort of edits. This is the main change that we're voting on here. And so as the guideline as edited with the change in the dose.
But the dose did not change, just to clarify for the vote. We are not changing it to 2 grams. We're keeping it at 1 gram.
But that's what we're voting on now.
An aye vote would change it to 2 grams, and nay vote would leave it at 1.
Correct.
In my estimation.
That's correct. Yeah. A yay vote would change the dose to 2 grams. A nay vote keeps it at 1 gram. Everybody ready for that?
I think so.
What were you gonna, Josh, were you gonna say something?
Josh, this is your conversation. I think you were a nay.
Okay. So all those in favor of changing the dose to TXA to 2 grams on this childbirth guideline, all those in favor say aye. Those opposed say nay.
Nay.
Any abstentions? Okay, that motion carries. Thank you. Okay, so moving on to item J, discuss, amend, and approve the T3G for general trauma management, also taking into consideration the TXA dose. This is attachment 5J.
Is the change, nothing's highlighted, is the change here also changing it to 2 grams?
I think the PEDS dose is double.
In the PEDS dose, okay.
Yeah, sorry, guys.
It's
Just
not
not
yellow,
yellow,
it's
it's
not
not
yellowed
yellowed
out. Yeah, I just want to make sure I know what we're talking.
Motion to discuss.
So I'm gonna push back a little harder on this one, mostly because I didn't do my homework until right now. There is fairly strong evidence to support the 2 gram dosing of TXA. The first evidence that I pulled up was an article published in the Journal of Acute Trauma Care Surgery in February of 2024. Their conclusion states, and I quote, clinical outcomes in 24-hour fibrinolysis states were equivalent across the 3 different dosing strategies. Single bolus administration is likely preferable to a bolus plus infusion regimen. The TCCC guidelines recommend for a 2 gram isolated dose alone. There is a combined position statement from NAMSP and ACEP that states, oh, I lost it, sorry. It states 1 to 2 grams of TXA is recommended as a bolus. I can't quote that because I lost it. Here it is.
Military guidelines, besides the TCCC ones, all their damage control resuscitation guidelines also list 2 grams of TXA as an initial starting dose.
There's a systematic review and meta-analysis and injury from 2023, and their highlight was when compared to standard dosing, high dosing, which was defined as 2 grams or 30 mg per kg, probably reduces transfusion requirements with good odds ratios, with an uncertain effect on thrombolytic events and mortality. That was their conclusion.
Sorry, I didn't catch who made the motion.
Josh.
So my counter comments to those are that the FDA approved dose for trauma is still based on the CRASH 2 trial. The 2 largest trials that have looked at TXA both used the 1 gram dose. There hasn't been as far as I know, the trials that were just cited, are those actually RCTs or?
The one that I said, it's a systematic review and meta-analysis.
Yeah.
Not RCT.
NAMSP, as Josh mentioned, still recommends anywhere between 1 and 2 doses, as does the American College of Surgery Committee on Trauma, if I'm not mistaken, as of mid 2025.
Franco, here I'd be happy with a range. And I have a question to Brian. I think TXA is relatively cheap, but is there anything that would preclude you from carrying 2 grams? Or would you still want to carry 1 gram for, say, drug box constraint reasons or just inertia?
Well, I think
But
the reason we carry 1 is because when we talk to our trauma surgeons about, at the time, it's 1 gram dose, do we need to start the infusion in the field? And the answer was no, that can wait until they get to the trauma center. So that was a result of that kind of dosing, and that's the reason we went with that. I mean, if we put a range down here, because that'd be totally up to Dr. Godstanker on how we run that anyway. I don't know that I've seen us given 2 grams in ours yet.
Yeah.
That I recall, but Dr. G might have a better answer to that than what I necessarily might or might not see.
copy.
It's not very expensive. That's true.
So again, what I would suggest to the board is keeping in mind, it's not, as Amber pointed out, of course, we can't expect perfect evidence base for all the decisions that we make, and that's not what I'm asking for in this situation, although it's pretty clear to me that earlier is better for TXA, but dosing regimen is a question that remains very, very wide open. And so really for me, it's that plus there's unclear safety and risk questions. It's unclear whether the opinions of Southern Arizona trauma surgeons speaks to the consensus across the state. Our professional organizations, NAMSP and American College of Surgeons, have not laid down a clear opinion on this to suggest that 2 is clearly superior over 1. And then there's a precedent setting issue for me, which is my biggest problem, which is, again, this seems to be mostly a pragmatic thing for one region. Why is that then this committee's, why is then that the basis for this committee to make this decision that has impacts across the whole state?
The recent evidence supports the 2 gram dosing. I don't think it's just pragmatic. Just because we changed a year ago doesn't mean that the evidence that has come out since then is not still valid. The evidence still supports the 2 gram dosing.
But I guess what quality of evidence? Is it really direct evidence of that, or is it sort of the secondary evidence based on trial subgroups?
Well, I don't think that we're going to get a 2 gram TXA trial anytime soon. So I think the evidence that we have, including meta-analyses, is kind of what we have.
Mm-hmm.
I don't see us doing a 2 gram TXA trial anytime soon.
So I'll only offer up additional evidence if you want more. Thanks to our very good fellows who are helping with our literature search on the fly here. The STAMP-2 trial, published in 2023 in JAMA Surgery, did compare the 1 gram versus a 2 bolus. And they found no differences in 30-day mortality. However, the 2 gram bolus group had lower rates of TXA-related complications, suggesting it may be reasonable as an alternative dosing. The patch trial, again published in the New England Journal of Medicine in 2023, stated there's no statistically significant difference in mortality, but subgroup analysis and meta-analysis suggest a benefit of early TXA given with 1 hour. So I think we can their intervention was 2 grams of TXA in that patch trial. They did not do a 1 gram arm. So I think we can very confidently say we have 2 fairly large, fairly well-designed, published in big journals that say 2 grams is effective and probably safer than 1 gram in bolus. But again, as we've said multiple times, these are guidelines. We can do whatever we want to do in Southern Arizona. We'll continue to do that. So.
Yeah. And again, just pointing out that the patch trial was a subgroup that showed that benefit in the most severely injured patients. But yeah, just to clarify that. Dr. Gamer.
Yeah, Franco. While I'm calling people out, why am I blanking on his name? Dr. Trauma doc from BEMSTS. Dabrowski. Paul. Yeah. Is Paul Dabrowski still on? What would he like or what would he reach for with the average trauma patient that Phoenix Fire rolls up in with? Would he reach for 1 or 2? I don't see him on anymore.
Well, yeah, I mean, valid question, except now you're talking about a hospitalized patient who's going to get, the 2 grams at some point anyway, right? And so a different population, but his input obviously would be valuable. Is he still on the call? Can anybody tell?
He's not, no.
Okay.
That's part of my malfunction. He's not still on, but I respect the Southern Arizona comment that you're going to do what you're going to do. And so here's where I think a range might be best, but that's just mine. I can see either way.
I think we're all totally fine with the range. And that's how the NAMSP position statement is currently written.
Aaron, go ahead.
Yeah, I think I remember when we first were talking about TXA and EMS having it, I thought the rationale was for long transport times. That's, in areas where, transport to the definitive healthcare center would be prolonged is how we originally started. Is my recollection. Correct me if I'm wrong. But then with the patch trial, which was largely a negative trial, saying that pre-hospital TXA didn't impact outcomes except for the subgroup that that was mentioned earlier. I guess for me, it'd be nice to know, A, how much are we using in the pre-hospital setting? And just kind of, whatever the trauma surgeons want, a lot of them are going to be administering it in the trauma bay. But I guess how much are we using in the field? And do we have any way of quantifying or getting any sort of metrics on that?
It's a lot. I don't know the exact number, but it's a lot.
We do have a medication report that Ann Bostring pulls on medication administration. So I don't know that I can find that in the next 7 minutes before we finish the meeting, but we are able to get the data on use of TXA in the state based on data reported to AZ peers. And that's just, don't know who could have been potentially eligible and didn't get it. We simply get data on if administered. And we don't get indication either. So it's just flat administration of TXA.
For what it's worth, Dabrowski said 2 grams single dose. And his answer to me. Thank you.
Wait, say that again.
I sent a message to Dr. Dabrowski and said that we were discussing TXA for trauma 1 versus 2 grams. And he said 2 grams single dose, but he's not available to be on the call right now. That's what he said.
All right. Well, so what would we like to vote on? Would we like to vote on increasing it to 2 grams, which is the original motion, or a range of 1 to 2 grams?
I'd like to address a friendly amendment to make it a range 1 to 2 grams.
Second.
All right, so the vote on the floor is a friendly amendment to change this motion to have the language say 1 to 2 gram bolus. All any discussion on the friendly amendment?
Just to clarify, then that would also need to adjust the pediatric dose to 15 to 30.
Do we agree that that would be a mandatory obligating change there?
Well, this, sorry, for some reason, the draft version is not not displayed, but the original version was 15 mg per kg. So I just want to make sure that this is matching that.
Okay, important distinction there. All right, so the friendly amendment is to change 1 to 2 grams, and then for the pediatric dose to remain adherent to that, it would be 15 to 30 with keeping a max of 2 grams, I guess, practically speaking, would be sufficient there.
Sorry, just for the pediatric one, would you write that 15-30 mg per kg? Because that makes it seem like you could do 20 milligrams per kilo or 25, but really it's like you're doing 15 mgs or 30 mgs, right?
Yeah.
You're not, there's not like a in between.
Thank you. Yeah, valid point. Yep. All right, any other discussion on this friendly amendment? All those in favor, say aye.
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 Any opposed? Abstentions? Okay. Any further discussion then to the changes on this trauma management page? Okay, so we will go ahead and have a vote to approve the general trauma management page with changes as discussed. All those in favor say aye.
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 Any opposed? Any abstentions? Thank you. And so in the 3 minutes we have remaining, can I get a motion to discuss, amend, or approve the optional agent minimum quantities on table 1? This is attachment 5K.
So moved.
I would suggest tabling it.
There's some concerns about some of the layout on here. Not that it's not moving it to taking away the minimum optional, but so there's some things that I think are some issues on the layout of some of these drugs. So I don't know if we can do that in 3 minutes.
Okay.
Motion to table takes precedent. So.
All right. So motion to table. Can I get a second?
Second.
All right. Can I get a vote to table that item? All those in favor say aye.
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 Opposed? All right. So please send any agenda items to be considered to Shelley, whose email is shown on the agenda. I will now place a call to the public. All right, for the sake of time, I won't go through the upcoming events in detail, but you can find those on the agenda. Our next meeting is November 20th at 12 p.m., virtual and in person. Motion to adjourn.
So moved.
Motion.
All right, thank you, everyone, and we will see you next time.
It was already
meeting.
out.
Great meeting, guys.
I'm gonna start right now, right after.